Good morning, everyone, and welcome to the APDA Minnesota Winter Symposium, Building Your Healthcare Team, Physical, Occupational, and Speech Therapy. My name is Anushka Sheel, and I am the Information and Referral Coordinator for the American Parkinson's Disease Association Minnesota chapter. Thank you so much for joining us today. We are extremely grateful to our speakers, Anne St. Jack, Sarah Zorowski, Daniel St. Clair, Dr. Kristen Pickett, Jamie Engebretson, and Stu Bauman for volunteering their time to present for us today. After some brief announcements from the APDA Minnesota chapter, we will move into Anne St. Jack's presentation about speech pathology and Parkinson's disease. She will share her presentation and then answer your questions in a Q&A session. Please feel free to type any questions that you have for Anne and for all of our speakers today into the Q&A section in Zoom. American Parkinson's Disease Association Minnesota chapter, or APDA Minnesota for short, is part of the largest grassroots network dedicated to fighting Parkinson's disease. And we work tirelessly to assist the more than 1 million people with Parkinson's disease in the United States live their life to the fullest. APDA Minnesota offers a variety of services across the state, and please visit our website to explore all that we have to offer. Our website also hosts a variety of publications, webinars, articles, and information that can help you understand Parkinson's disease. If you're participating from another state, we have chapters and locations throughout the United States, and you can find that contact information on our website as well. APDA Minnesota is available through our helpline, our email address, and our website, as well as our social media handles. I would like to offer a special thank you to our Winter Symposium sponsors. Our gold sponsor, Kiowa Kirin, our silver level sponsor, Amneal, and our bronze sponsor, Acadia Pharmaceuticals. Our first speaker today is Anne St. Jack. Anne is a speech-language pathologist at the Minneapolis VA Medical Center, where she has worked since 2005. She received her Bachelor's of Science degree in Communication Disorders at the University of Wisconsin-Whitewater, and her master's degree at the University of Minnesota. And she currently works with our nation's veterans, many of whom have suffered from strokes or are living with Parkinson's disease. She is the chief of speech pathology and the facilitator of the Minneapolis VA's Parkinson's disease support group. Anne provides communication therapy through Lee Silverman Voice Therapy, or Lsvt, and the Speak Out program. And she also addresses swallowing and cognition. We're so excited to have her with us today. Anne, welcome and thanks so much for joining us. Please feel free to share your slides with the audience.
Will do, thank you. Let me do that. Anushka, can you see my screen?
Yes, I can.
Okay. And just my title screen, right?
Yes.
Okay, very good. Well, thank you everyone for coming today and learning more about how you can participate in rehabilitation and these therapies. My goal today is to, first of all, let you know I have no financial relationships to disclose, and more importantly, for us to talk about how Parkinson's disease can affect voice, speech, gestures, swallowing, and thinking. And while the time I have to speak about all of those is very short, it means I'll just be skimming the surface. The bottom line is that it is so important for you to have a consultation with a speech pathologist so that you can at least learn more about these areas and to maintain your progress with that, maybe even improve it. Many of us know the common characteristic symptoms for Parkinson's disease: tremor, rigidity, akinesia or bradykinesia, and postural instability. While that has implications for the body at large, it also has implications in what we work on in speech pathology. The tremor can affect sometimes your tongue or mouth. Rigidity can also affect your tongue or mouth. That stiffness, so that when you're swallowing or talking, it affects your speech or eating. The bradykinesia can result in having this lack of movement or this slowness in your swallowing, causing you to hold food in your mouth or have a prolonged time of moving the food in your mouth down toward your throat. Postural instability plays a big role. When we're forward, we're not able to talk to our listener, or we might have more drooling because of our posture. So those are some areas that Parkinson's can affect our speech and swallowing. So what are some things you can do about your voice? Certainly the old adage of use it or lose it is so true. I encourage you to stay socially engaged. And I know that's a tall order right now with the pandemic, but having you do these things either virtually or in person keeps you using your voice, using your communication. So I encourage you to attend support groups, visit with friends by calling them on the phone or scheduling a Zoom time or a FaceTime. Having you volunteer so that you are out there engaging with people. We'll talk about some vocal exercises you can do, and even singing, how that helps. One of the biggest ways to keep your voice strong or make it strong and your overall communication better is by focusing on articulation. That is the best way to be more intelligible or better understood by others. When you focus on enunciating or speaking clearly, your articulation improves. Another way of doing that is by prolonging your vowels. I'm not sure that we in Minnesota need to do that any more than we might already, but that's another means of making your words better understood. Certainly, decreasing your speaking rate so that it's at a meter or pace that others will better understand you. So slowing down. And sometimes we have people use a pacing board so that they can kind of tap out each word or syllable that they're saying. Many of you have heard about Lee Silverman voice therapy, Lsvt Loud, or even a different program called Speak Out. Both of those are meant for you to speak with intent. When you speak with intent, you're usually louder. And yet we want you to speak within normal limits, not shouting or screaming, but Parkinson's tells the brain that you're speaking at this volume when in reality you're speaking much lower. So we need to recalibrate the brain and do that in an intensive program. Those programs of either Speak Out or Lsvt have multiple sessions for each week for 4 weeks, with each session being about 40 to 60 minutes. It also includes daily homework practice and carryover exercises. But when you utilize these techniques and make them a part of your everyday routine, being louder and speaking with intent triggers you to take a deeper breath, open your mouth wider, which improves your articulation and can reduce your speed of talking. Really, one of the biggest things with Lsvt or Speak Out is to do one thing. Speak with intent. Live with intent. It's not open your mouth. It's not talk louder. It's I'm going to communicate with intent to the person next to me. Within these exercises and others, we also look to improve inflection or your pitch. With Parkinson's disease, our pitch range really shrinks. We want to keep that a wide range. So certainly in Speak Out and Lsvt, there are some pitch glides. Some other ways for you to take a look at your own pitch are to do some voice recordings. Maybe you have some old CDs or tapes laying around of you talking years and years ago. Maybe listen to those and then record yourself again and see if there's a difference. Likewise, also consider recording you telling an exciting story. When you listen to it, does it really sound like an exciting story? Or is it pretty flat and monotone? Those are some areas we can work on. Another means is to do a video recording. Now you're not just listening to your voice, but looking at the whole package, and we'll talk about that too. This has some real life implication because if you're doing a Zoom meeting or a FaceTime with your grandkids, you can see what they see when you are communicating to them. You can hear what they're hearing. That type of biofeedback has some really great utilization. One thought is for you to say some functional phrases. These are mine, my top 10, if you will. You might have your own, but they're phrases that you say at least once a day, maybe every other day. Good morning, turn off the lights, please. Did you get the mail? And so on. Going through these, looking at your pitch, do you have inflection when you ask a question? Are you speaking with intent? Will the person who you're saying this to truly understand what you're asking? When we go through these phrases, we say every single day, we're going to practice what we need to. And so with that, practice is key. Doing these exercises is what makes your voice stay stable and improve. Once people do not do these exercises, then we see the decline. And so with this intense voice therapy, it has these spreading effects or a cascade effect, so that when you speak with intent, your speech improves, your articulation improves, and some research indicates that your swallowing improves. There's also research to say that singing improves your voice. If that is more along your lines, then by all means, go ahead and do that. Now I'm going to talk about pragmatics. What is pragmatics? Pragmatics is all the fluffy stuff around how we communicate. It's our facial gestures. It's our hand gestures, our posture. It's whether we initiate a conversation and ask further questions, or do we not respond that way? It's if we can stay on topic, or do we kind of go off on a tangent? And how good are we at eye contact? Now I realize that all of these have a baseline as to how we were maybe 20 years ago, long before Parkinson's was a thing in our world. And so we want to do a check as to where our pragmatics are from that time period, because some of us are not the best at staying on topic, even 20 years ago, or not the best at eye contact. So taking that into consideration. Here are some ways to improve pragmatics in Parkinson's disease. Having you look in the mirror. Now, certainly meeting with a speech pathologist and going through these. What are your facial expressions? As you know, many people with Parkinson's have a quite flat affect where they aren't very expressionful when they're sharing a story. When you look in a mirror, you can see how well you share that information. Is what you're saying matching how you look? So it also doing some of those facial expression exercises will improve your range of motion. Are you able to smile? How big can you smile? Things like that. Here are a few exercises that you can do. Raising your eyebrows as if you're surprised, or furrowing your brow as if you're disgusted, and so on. Something else to consider is how often you blink. This certainly has implications for our pragmatics, so that you may not come across as staring at someone, but also if your eyes are dry, considering that as well. I also want to talk about being ready to communicate and to be able to share what's on your mind. When we have a posture that is ready to communicate, it looks like this, where our mouth is closed at rest. And what that does is it decreases our drooling when our mouth is closed, and it makes you ready to talk versus needing to close your mouth, swallow, and then start talking. That posture alone gets you ready to communicate. It doesn't allow much time in between for you to forget what you were going to say. Our posture is very important, and I'm sure you'll hear a bit more about that, maybe within the subsequent talks of the occupational and physical therapists. It also has implications for how we communicate and swallow. With your head up, your trunk and abdominals turned on, and your lips closed, allowing you to breathe through your nose, you can be ready to communicate. It allows better breath support so that you can talk loud and take a deep breath to be able to talk louder. It gets your head up so that you're speaking to your listeners' ears, not their bellies. Likewise, they can see you and you can see them as to whether they really understand what you're saying. If they're just saying, uh-huh, but they have this quizzical look on their face, now with your posture ready, you can determine they didn't catch what I need to, what I said. So certainly you can, that is why the physical therapist might work so much on posture. Another thought is to have you advocate for yourself. Stick up for yourself. You might say something like this: sometimes my facial messages don't match my interest in this conversation. I'm working on it. Or sometimes my face doesn't match my emotions. Ask me how I'm feeling about our conversation. That way, it kind of puts things on the table so that you can talk about it with others. The next topic I wanted to share about is that of swallowing in Parkinson's disease. Swallowing problems are called dysphagia. Here are some signs of swallowing problems or dysphagia. If you are coughing or choking during or after meals, if you're clearing your throat during or after meals, if your voice sounds wet during or after meals, or if you're holding food in your mouth longer than you might have before, or if you're pocketing food in your mouth, so after you've swallowed, you still have food in your mouth. Or if you have longer meal times, say you're the last one at the table all the time by quite a bit of time. Or if you have excessive saliva or drooling, or if you have trouble starting the swallow. Those are some signs that we'd want to take a look at your swallowing. The reason swallowing is so important is because aspiration pneumonia is the leading cause of death for people with Parkinson's disease. So let me explain what that means. Aspiration is when some foreign object goes into your lungs. You're aspirating it. That can be food, liquid, medications, or your own saliva. And so when we know that aspiration pneumonia is the leading cause of death for people with Parkinson's, we want to be able to evaluate it and treat it. And we can do that. Swallowing safely is important, and usually in speech pathology, we can do something to improve it, to make your swallowing safer. Certainly, there are multiple reasons why our swallowing can be impaired, or and so some of those are that you might have weight loss, unexplained weight loss, or you might have a change in your diet as to how well you can chew things, maybe because of your teeth. Dysphagia or swallowing problems can also cause dehydration and or anorexia, certainly on a much more severe level. But we want to be able to take a look at it. Having said all that, we know that eating and drinking and certainly taking your medications is really important for our quality of life and for people with Parkinson's. Let me back up and show you, do a little anatomy lesson here with the picture. This is a side image of our head and neck. Here is our nose, our lips, and our teeth. This is our tongue. Our tongue is quite big. This is the roof of our mouth, our hard palate, and then extending into our soft palate. This is a knee-like area where it kicks up, right? When we say e, 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 that's what happens here. This is our epiglottis, and many people affectionately call this the flapper. That's what it's really called, is the epiglottis. Our vocal cords sit right here. There are two small muscles right here at the top of your trachea. Your trachea is this front tube, and immediately behind that is our food tube, or esophagus back here. When we eat, we put the food and liquid in our mouth, we hold it as a ball, and then if we need to chew it, we chew it, and for the most part, keeping it together in a ball. And then when it's ready to move toward the back of our throat, our tongue pushes up and we push it back. And when the food or liquid gets to the base of our tongue right here, a lot of things happen, and all at once, and without us thinking about it, literally. Our velum or soft palate kick up, creating this knee-like action so that nothing comes out our nose. Our epiglottis folds down and inverts over the top of our vocal cords. Meanwhile, this whole area kind of moves up and forward and does that with this bone here, or hyoid bone. That's why when you see some people swallow, their neck muscles are literally moving up and forward. Not a whole lot, but some also in speech pathology, we will literally put our hands on your neck to feel for that so that you're moving up and forward when you swallow. So we have your soft palate kicking up, closing off the port to your nose. Your epiglottis is inverting down so that no food or liquid go into your airway. And meanwhile, your esophagus opens up. This picture is a little misleading because your esophagus at rest is closed. Like right now, when none of us are swallowing, our esophagus is closed. But as we swallow, then it needs to open. And then the food and liquid goes down into your esophagus and stomach. Dysphagia happens when we hold food in our mouth, or when we have a hard time moving the food from the front to the back of our mouth, or it takes a lot of effort. At the onset of the talk, I talked about rigidity and how our tongue can be rigid. And that can happen here too, where our tongue isn't as strong, and so it can't literally push that ball of food back as efficiently as it once did. Subsequently, what can happen is food or liquid can go into our airway. That is called aspiration, when it goes below your vocal cords. Sometimes we cough, and you should cough, and sometimes people with Parkinson's do not cough because their cough response is weakened. So that is something that we can work on. One of the ways that we evaluate your swallowing is to do a swallow study with radiology. I feel that this should be done with all people who have Parkinson's disease so that we can have a baseline of your swallowing function. It may identify mild signs of dysphagia or swallowing problems which can facilitate earlier intervention, meaning getting you started on some therapy sooner rather than later. The swallow study was developed in 1971 to look at your mouth and throat portion of swallowing. And that's literally all that it looks at. So just below your eyes to just the top of the bottom of your neck. The goal of this is for us to replicate an eating scenario with your natural posture, foods, and you feeding yourself if that's how you do it. And because of that, we also want your normal medication schedule in place. So what are some things that we can do for swallowing? There are some exercises that we can do, which I don't have listed here. But the reason for that is because I would recommend that you do that in concert with a speech pathologist. Also, something that's on the market and yet something I would ask you to seek help from a speech pathologist again, though, is this tool called the Expiratory Muscle Strength Trainer, or the EMST 150. Here is a picture of that little device, and I have one here too, just to give you a sense of how big it is. Some of you are familiar with an Inspirometer, that little white clear tubing that you use to inhale and expand your lungs, typically after a surgery, so that your lungs keep moving and can still inhale. And this device is working on your exhaling. One would say that in order to work on your exhaling, you also need to inhale, and the inverse is true too. So really, when we're working on either of these, we're working on both inhaling and exhaling. This device is a calibrated, spring-loaded device with a one-way valve. It has a check valve in it. The goal and directions are for you to blow hard and fast to open this valve in here, like this. The program is for you to do this for 5 weeks, 5 days a week, and 25 breaths a day. The breath I just did was 1 of 25. And literally with the program, it takes 9 minutes, 9 to 15 minutes. Why would we do this? The goal is for you to improve your throat movement in having your throat move up and forward. And overall, it decreases your food and liquid going toward your lungs. It also improves your ability to cough out material in your lungs. That's important because if food or liquid is going into your lungs, we want to get that out. How do we do that? We cough. If you don't know to cough, we need to have you be more sensitive in coughing and having you have a stronger cough. So that's the goal of the Expiratory Muscle Strength Trainer. Of note, the most research was initially done specifically for people with Parkinson's disease. Since then, many other categories have been added to that list. Athletes, singers, deep sea divers, because of the amount of pressure that is loaded on this device, and to work on your breathing. So it's a pretty neat device. Also talking about your swallowing, a great recommendation is to make sure that you're taking good care of your mouth by brushing your teeth at least twice a day with a toothbrush. That level of friction, not hard brushing, but just using a toothbrush, helps you get the bad bacteria out. People with Parkinson's disease have had more complaints about their oral health and have more problems in oral health than the general population. Because of that, they're at risk for periodontal disease. There's a lot of reasons for that, right? Your tremors within your hands or rigidity within your hands or even your mouth can interfere with that. So certainly talking to your dentist about that. And some recommendations have been that maybe people with Parkinson's disease should go to the dentist more than just twice a year. Also, xerostomia, or dry mouth, is a common side effect of medications. When you have dry mouth, that bad bacteria can stay and linger in your mouth more and can result in tooth decay. So we want to keep your mouth as clean as possible so that bad bacteria doesn't also go into your lungs. The last topic I want to talk about is cognition and thinking in Parkinson's disease. This is quite a big topic that we can also work with not only the person with Parkinson's, but also their family members to help support. We work on areas including memory, attention, sequencing tasks, organizing your day or schedule, problem solving, and planning. I think of it as if you needed to go to an appointment, all the things that it takes you to consider in order to get there on time with the things that you need. But really, in a day-to-day event, that can kind of be boiled down to some of these topics here. We meet with people to come up with some systems or to place some structure so that even if you can't remember things, you can use, say, your smartwatch to set reminders or alarms, or to have written information for you to refer back to. Maybe you use a whiteboard like pictured here to write down your morning routine so that you don't forget to brush your teeth, that it's listed, go to the bathroom, take my medications, brush my teeth, shave, so that those things are consistently done in that routine and that is posted there in the bathroom. Or maybe you use your calendar a little bit more, writing down your appointments or even little things that you want to do. Call Susie at noon so that it's something that you are looking forward to. So cognition or thinking is also an area that speech pathologists can work with you on to help create some systems, be organized in being able to be a little more independent and safe in taking your medications, arriving at appointments, or doing everyday tasks such as getting your lunch ready. In conclusion, exercise is medicine, and certainly I think you're going to hear that more later on today. So the goal is to keep you moving. And what I mean by that in speech pathology is keeping your voice going, having you talk, be involved in social interactions, having you continue to swallow, having us take a look at that. So I'd implore you to ask your neurologist or your primary care physician to have you see a speech pathologist to at least see the options that we can work with you on.
And thank you so much for that very informative presentation. And we have some questions that have been submitted by audience members. So I wanted to encourage everyone, if you have a question for Anne, you can ask your question using the Q&A feature on Zoom. So the first question that we had come in was regarding oral health. The person said, flossing and brushing is hard for me because of my tremor and my stiffness. Is there anything that you can recommend to help with that?
Great question. Certainly talking with your dentist or your dental hygienist as well. So circling back to them as well. Some people find using an electric toothbrush to be helpful because then you don't actually have to do the movement. And sometimes those brushes are a little bit bigger so that you can hold it a little bit with a different grip. Flossing is hard because historically we got to use our 2 fingers, but sometimes those little picks are helpful, or some of my patients also use a water pick instead of the traditional floss itself. So again, another tool that you use that like at a higher pressure shoots water into your mouth instead of the floss.
Great. And another question has come in about attention and focus, so more of the cognitive side. This person has said, my attention and my focus has been impacted by Parkinson's. Do you have any recommendations for how to improve or train my attention span?
That's a great question. And we see that quite often. One thought is to, again, see a speech pathologist to kind of have a more focused and personalized approach to that. And yet some more basic suggestions are trying to pare down what you need to pay attention to. So eliminating some distractions. If you are trying to pay your bills and the radio or TV are on, turning that off, or making sure you're in a well-lit area, or performing those tasks when you're more at your prime during the day. If that means in the morning, you're more awake and able to focus, then doing that. Also, sometimes setting timers for yourself. So saying, I'm going to work for 25 minutes on this task. Then I'm going to give myself a 5-minute break and set a timer either on your watch or in the kitchen microwave timer relative to that. So kind of, I got to get this done, but then I'm going to give myself a reward, if you will. Or prioritizing what you need to do, doing the most important thing first so that you're able to get that done.
Great. I think that's super helpful. I mean, advice even for me. So
it is. It's good for all of us. Yeah.
And then someone else asked, I'm wondering, why does Parkinson's disease tell us that we're speaking more quietly than we are? How does that work?
That's a great question. Parkinson's disease tells the brain that you're performing a lot of things at normal level. You're swinging your arm at your normal level. You're taking your normal steps, but really it's much minimized than that. And so that's the part in the brain that is that feedback loop and minimizing your actual from reality. So we can, at least in voice therapy and also via LSVT big, things like that, retrain our brain, literally recalibrate it. So we're recalibrating our brain and our muscles too, to speak louder, to open our mouth more, so that you can return back to that more functional state beforehand.
That is really interesting. And I have another question. Someone said, if coughing isn't enough to clear your mouth and throat when you're having swallowing issues, do people ever start sneezing a lot? I think they're having some issues with like sneezing quite a bit.
Yeah, that's some. It can be a symptom of dysphagia as well. So that is something that you could consider having checked out as well. Some people do sneeze more often, and how that might be is that when you swallow, your soft palate may not be kicking up like it should be. And so some of the food or liquid is coming out into your nose. You may not be feeling it in the moment, but that might be triggering that sneezing response.
I've never heard of that before, so that was really interesting.
Yeah.
Someone's asked, where can I get the Expiratory muscle strength trainer?
Of course, you can buy it on Amazon. I am not joking. It is on Amazon. There is a website also based on the product through Aspire, ASPIRE. I'm not here to endorse anything. They're not paying me to say that, but it is quite a program to do that. There are some contraindications though, making sure that you don't have significant heart disease or things like that. So it's not advised for people who are currently pregnant or at least under direction from your physician. because you are putting quite a amount of a load or a pressure on your head and neck area too. Certainly if you've had any surgeries to your head and neck area as well. Yeah. But it is a good program. It certainly has a maintenance program as well. I spoke of the 5 weeks, and that's the real go get at it and make you stronger. But then after that, there's a maintenance program for you to continue on doing 2 to 3 times a week. And that's true for a lot of probably what you're going to hear in these subsequent talks too, are that we have a lot of exercises that all of us should be doing every single day. So that would be adding the EMST to your wheelhouse as well.
Great. I think that's really helpful. I think that maybe the person was wondering if they needed a prescription. So that definitely answers the question that you can just, you know, get it, but you should see it. You should be under the care of a speech pathologist to help as you go through the process.
Yes. At our facility, we also do some testing before we issue the EMST. So first, we do the swallow study. And then secondly, we test how hard you can blow, how hard you can cough. So we have a different tool that we use to measure that. And then, if indicated, then we institute the use of the EMST. And then afterwards, we take those same measures again with this different tool. And you know, in our clinical world, there are certain values that indicate whether you are more likely to aspirate or not. And that's even true specifically within the Parkinson's disease community. So that's how it could be truly beneficial to you by seeing a speech pathologist along that line.
Great.
So,
Great.
and meanwhile, many other people reportedly say, people who have used the EMST, boy, I used to cough a lot before when I was eating, but it was very weak and I never really felt like I could clear anything out. Now, after I've used the EMST, my cough is a lot less frequent, but when I cough, it is hard and effective. And many family members also appreciate that too.
Absolutely. That was super helpful. And I think someone else has asked a question. How do we keep from running out of breath or having our voice trail off while we're speaking? Do we use shorter phrases? Should we take deeper breaths?
Both answers are correct. Yes. So having you speak and having to breathe more frequently, and then also having you continuing to speak loud so that everyone can hear everything you're saying, right? So that takes a lot of effort and thought to be able to do that. Some of the exercises that I spoke about with your voice are going to train and strengthen your voice so that you can have longer phrases, so you don't need to take as frequent of breaths.
Great. And I have another question, probably the last question we have time for today. Someone has asked, how do we enroll in Lsvt?
Very good question. Both Lsvt for loud and big and speak out needs to be delivered by a certified clinician. So they have had extra training in that. Lsvt and Speak Out both have websites that indicate who has been a certified clinician. So you can literally go on their website. Lsvt is lsvtglobal.com, I think, and you can type in your zip code and see who in your area is certified. Some patients need to have a stroboscopy, so they need to have an ENT or a speech pathologist look at their vocal cords prior to starting Lsvt. And so there's more information about Lsvt, and then also Speak Out. Speak Out is at Parkinson's Voice Project. They're out of Texas, and that's a fantastic program as well.
Great. And I think with that, that brings us to 10 a.m. So thank you everyone for asking questions. And if we didn't get to your question today, I really recommend that you consult with your speech therapist or physician. And again, thank you so much for taking the time out of your morning to join us. We really appreciate you being here today.
Thank you. It was my pleasure.
Great. And we will now take a 5-minute break, and we'll be back at 10:05 for our next presentation, which is all about using occupational therapy services to optimize your health and well-being. Welcome back, everyone. Our second speakers today are Sarah Zorowski and Daniel St. Clair. and Dr. Kristen Pickett as well from the University of Wisconsin in Madison. Sarah teaches graduate courses in the Occupational Therapy program at the University of Wisconsin-Madison, and she received her undergraduate and post-professional doctorate degrees in occupational therapy from UW-Madison in 2002 and 2020. She joined Dr. Kristen Pickett's Sensory Motor Integration Lab at UW-Madison to explore OT's role in supporting the physical and mental health needs of individuals living with Parkinson's disease. Daniel St. Clair is an occupational therapy student intern from the University of Wisconsin-Madison, and he received his recreational therapy degree in 2016 from the University of Utah. He began working with individuals with Parkinson's in 2016 when he worked as a cycling team lead for the National Ability Center in Park City, Utah. So Sarah and Daniel and Dr. Pickett, thank you so much for being here today. Welcome. And please feel free to start sharing your screen so you can dive into your presentation.
Great, thank you very much. All right, that should do it. Let me just get my notes up here and then we will start. So thank you, Anushka and the Minnesota APDA for inviting us to speak today. And after almost 20 years of being an occupational therapist, I still get really excited to talk about our profession and how we support our clients. So I'm joined today, like we said, by Dr. Kristen Pickett, who's a researcher at UW-Madison, who will join us at the end of our presentation to talk about her work. So often when we do these types of talks, oh, and Daniel's with us too. Hello, Daniel. He's going to help me do the presentation as well today. So often when we do these types of talks, people hear the word occupation and ask us, do you help people find jobs? So no, we don't specifically help people find jobs, but what we do help people do is participate in their meaningful daily activities or occupations, as OTs call them. So here is our agenda for today. First, we're going to talk a little bit about what OT is based on. And it's this idea that there is a strong link between the things we participate in on a daily basis and our health. Next, we're going to cover a little bit about what OT is and some of the benefits of our services, as well as how to access an OT and talk about when it's a good time to meet with an OT. We're also going to provide you some steps that might help you solve your everyday challenges that would help you think kind of the way an OT would think. And then we're going to end today with Dr. Kristen Pickett talking about some of the exciting work that's being done at UW right now. So before we continue, I do also want to let you know that everything we talk about today can be found in our handout that Anushka emailed you. So let's get started. I'm going to pass it off to Daniel.
Thank you, Sarah, and hello, everybody. I'm really excited to share this time with you. So let's dive right in. Before we continue, I wanted to quickly discuss the term health. It is often misunderstood to mean just physically healthy, but in reality, a state of overall health is made up of many more components. And as occupational therapists, we have adopted the definition of health from the World Health Organization as not merely the absence of disease, but a state of physical, mental, and social well-being. OT really is based on the theory that participating in our everyday activities, or occupations, as OTs call them, is central to our identity, health and well-being, and bring a sense of meaning and purpose to our lives. So just to summarize it, in short, OTs help people live life to its fullest, no matter your health condition, disability, or risk factors. And we really enable people to live life to the fullest by helping people across the lifespan to participate in the everyday occupations that people want, need, love, and are expected to do. Now, you might be asking, what occupations do these include? They include things such as activities of daily living, which encompass items such as brushing your teeth, like we talked about before, cooking, and dressing. They also include household management, like washing dishes, as well as rest and sleep, health management, like exercising or taking your medications. And in addition, they can include things such as work, paid or unpaid, like volunteering, leisure activities, and social participation.
So now that you understand generally what OTs do, what might it look like if you were to visit an OT? And although this might vary depending why you are seeing an OT, the process is pretty much the same though. So an OT will always spend time getting to know you and what's important to you, all while asking about your everyday tasks and the things that you're having difficulties with. And once we have this information, we kind of become a little bit like investigators that look for the barriers and reasons why you might be having these difficulties. And there are several different types of factors that can impact a person's ability to perform everyday activities. And OTs recognize these, which I have depicted in these interlocking circles, as personal factors. So meaning anything that sort of resides within yourself, your physical abilities, your cognitive abilities, as well as environmental factors. So anything sort of outside of you, meaning your home environment, your community, and the actual demands of an occupation or a everyday task. So that would be like steps to complete the task, time it takes, and the skills that you might need. And what we recognize as OTs is that these factors are all interrelated, which is why those circles are overlapping. And to be successful at completing your occupations, these factors need to be well aligned and matched. So to make this a little clearer, we have some examples of how we might address specific personal factors, environmental factors, and occupational factors. So on this slide, I've listed some personal barriers that can impact a person's ability to do their tasks that they need and want to do. And this really can include anything related to a person's physical health, emotional health, as well as their cognitive and thinking skills. So oftentimes, a lot of our clients have difficulties completing their self-care tasks due to decreased range of motion, strength, or endurance. And we can offer individualized exercise programs to help address some of these challenges, as well as work with our clients to find alternative ways for them to stay engaged in their occupations that keep them moving and active. I think this is a theme that you're going to hear throughout all three of our presentations today. So for example, if you're a person that really loves to do yoga, but you can't really get on the floor anymore, or your balance isn't as great, we could recommend a seated yoga program designed for people that can no longer get on the floor. For clients that find it physically challenging, maybe to bend down to put their socks on, OTs can provide adaptive equipment, such as the sock aid that I have pictured at the top right here. And to use this, you would slip the sock over the sock aid and use the cord. I know they might be a little bit hard to see, but there's white cords that serve as handles, and you would lower that sock aid to the floor, help put your foot in the sock, and then use those cords to put that, pull the sock up and over your foot. Oftentimes, clients can experience a variety of mental health challenges as well, like depression or anxiety. And that can really interfere with our ability to participate in our desired occupations. So OTs work with our clients to promote their positive mental health by encouraging them to participate in activities like meditation or mindfulness. And a little bit of overlap with Anne, who talked to us about kind of thinking and memory difficulties. OTs do take a look at that as well, because we know that that can serve as a barrier to performing some of your everyday tasks. And so similar to what she had talked about, kind of hanging visual cues or using timers and reminders just to kind of help jog your memory. But we also encourage our clients to really participate in activities that keep your brain active as well, such as doing puzzles, playing cards, reading, or maybe even learning a new skill or hobby.
To treat the environmental factors that impede participation, occupational therapists actively address physical and institutional barriers. Currently, we are actively involved in lobbying efforts at both the state and federal levels. This includes working on passing legislation that provides support and care for caregivers in addition to lobbying for OT telehealth services to be reimbursed. This will increase access for patients who live in rural areas, make care more accessible, and hopefully drive down costs for patients. We also advocate for accessible community spaces so that all individuals are able to participate in community gatherings and activities like outdoor markets. We play a large role in recommending home modifications so that our clients can continue to safely live in their homes. For example, in the bedroom, we often recommend equipment like a bed ladder or a strap, and this will help you roll over in your bed and increase bed mobility. In addition to addressing safety precautions and barriers inside the home, we recommend outdoor modifications, like that installation of railings on steps so that you can safely get into and out of your house. Lastly, we may also address factors related to the activity or occupation itself by modifying or adapting the task to make it easier to complete. For example, with a complex task that involves multiple steps, such as planning and shopping for the ingredients to a meal, we could simply simplify the process by helping clients create and use a standardized grocery checklist, like the one shown above. That way, clients can simply check off what they need rather than writing everything out. To address fine motor difficulties that may make tying shoes challenging, we often recommend the use of alternative shoelaces, such as the one you see here. Or we simply recommend that somebody wears slip-on shoes. To adapt the way somebody may reach for items that are on the ground or above their heads, we also recommend the use of adaptive devices such as reachers. By preventing you from bending over or leaning back, these devices can help you stay balanced and prevent the occurrence of falls. Lastly, for somebody that may not have the use of both upper limbs, we recommend the use of an adaptive cooking board, where the client can either clamp or use the protruding nails to stabilize the ingredient while they cut.
So next, we're going to go through a PD-specific case study just to help you maybe better understand the OT process as it relates to a specific case. So this case that we're going to highlight includes a husband and wife from a larger city here in Wisconsin, and they're quite active in their PD community. So they attended a lot of PD-specific classes and support groups in the community. So the husband has PD and has recently also experienced some additional medical concerns that have really impacted his endurance, strength, and ability to care for himself. And in the OT evaluation, the couple identified the following concerns as their top priorities, and you can see those listed on the slide there. The husband had difficulties maneuvering in his home, especially in the kitchen during meal times, and was having a lot of challenges showering and getting dressed independently. And then, as we can kind of all relate, the couple stopped engaging in a lot of their social activities, like attending their tango class and playing cards with family and friends, due to concerns with the husband's health and also the ongoing pandemic. And so after determining this priority list, like I mentioned before, the occupational therapist starts to investigate the personal factors, environmental and occupational factors that might be limiting participation in these activities. And so as you can see on this slide, we started with kitchen mobility, and I have listed on the left of that chart the personal, environmental, and occupational barriers that we determined through our evaluation, and listed on the right some of the OT type solutions. And so in meeting with the couple and learning kind of about their daily flow and the types of things that they do, we learned that the couple typically ate in the living room while watching TV. And then the man expressed that he really felt unsafe walking his plate and forks and knives and those sorts of things to the plate, or to the sink. And then we also learned that his physical therapist had also prescribed a walker for him. And so we really encouraged him to use that walker and we also recommended adding a tray to it so that he could carry his dishes independently without having to worry about losing his balance while walking and holding that plate at the same time. And then as a part of the home assessment that we did as well, we identified that there were some fall risks and hazards in the kitchen area. And so we really encouraged the couple to remove all of their throw rugs just so that he could safely use his walker and would avoid sort of tripping over those rugs.
Upon further evaluation, the OT determined that the client had difficulties showering independently because of his tremors and the decreased endurance. Therefore, the occupational therapist worked with the client and the wife to help reschedule his showering routine to align with the on phase of his medication. We also recommended that the husband increases endurance by completing 5 minutes of showering independently before his wife provided any assistance. And then we could gradually work towards reaching 10 minutes of showering independently. In addition, during the home assessment, the bathroom was generally considered to be unsafe, so a few modifications were recommended. This included the installation of grab bars and a shower chair to help with endurance and provide stability to prevent falls. Lastly, it was revealed that the couple was feeling sad and depressed due to the decreased social interaction caused by the ongoing pandemic, which, as Sarah, I think we can all relate to. To address these mental health challenges, the occupational therapist recommended activities like journaling, mindfulness practices, and provided them with online support groups and presentations like this one. The therapist also recommended using alternative social interactions like Zoom to play games and visit with family and friends. However, the couple did have some difficulties with using this technology. In response, the therapist provided them with the resources to find tech support and education.
So we hope that this case study makes it a little bit more clear how OTs problem solve and assist our clients in participating in their everyday occupations. And we really encourage you all to start thinking like an OT so that maybe you could tackle some of the challenges you might be experiencing, because we know that there are mental and physical health benefits of staying engaged in the things that are meaningful to us. So you can follow these steps that I have listed here that can help. And then I also wanted to point out that Parkinson.org has a great resource on their website. The page is titled Be Your Own OT. And we've provided that link to the website in our handout because it might be helpful to refer back to after this presentation. So what happens if you're not able to solve your own daily activity challenges or your own occupational challenges? We do recommend that it might be time to see an OT if that is happening.
So, as Sarah mentioned, it is important to contact an OT when you're having challenges or limitations in your ability to participate in your daily activities that you cannot solve on your own. Another time one may consider seeing an OT would be to prevent the occurrence of future challenges that may arise with any progressive disorders. Lastly, one of the biggest reasons to consult with an OT includes any time there is a concern regarding the safety or self-reliance of an individual. For example, OTs often address and assess driving safety, as well as the cognitive challenges that may interfere with independent living.
So similar to speech, in order to access OT services, you will need a referral from a doctor, and that can be a neurologist or a general practitioner. And before seeing your doctor, we encourage you to make a list of those daily challenges you're experiencing. And again, we have another great worksheet that is on the Davis Phinney Foundation website that we've provided you a link to. It's it helps sort of organize your thoughts and set goals for yourself before seeing your physician. And so it can just be a great way to help organize your thoughts. So then at your next appointment with your doctor, you can discuss that list of concerns and let them know that you would like to see an occupational therapist, and then your doctor can make a referral at that time. And I do want to be a little bit honest in that if you see an occupational therapist, they may not be an expert in all things PD, because as it sort of stands right now, most people with PD are going to see an occupational therapist after a significant injury or following an unrelated surgery like a knee replacement or something like that, or when a person is experiencing significant declines in their ability to care for themselves. But the good news is that we are actively trying to increase the number of OT and PD experts. And there certainly are PD and OT experts across the country, but we are actively trying to increase those numbers because we realize, kind of leaders in the field recognize that people with PD like yourself have everyday challenges that can occur at any stage, not just when a significant event or surgery or something like that happens. So in order to do this, we're training the next generation of OTs like Daniel here to be better able to meet a person's needs that's living with PD, as well as doing actively designing research to demonstrate OT's effectiveness with folks with PD. So to talk about this exciting research being done in this area, I'd like to invite Dr. Kristen Pickett to talk about her work.
Thanks, Sarah. So my job today is not to talk about research, which is a very hard thing for a researcher to do, but we want to focus on healthcare today. So I'm just coming on for a minute to talk a little bit about the fact that my job as a researcher in my lab is to partner with great clinicians and organizations like the APDA, and especially with individuals with PD, such as yourselves, so that the things that we do are informed by the experts in the field and people who are living with the conditions that we're working with. So our research is focused on providing evidence for practice and interventions that focus on helping older adults, especially individuals with PD and their caregivers, age in the way that they want, so age healthily in place, and promoting health in partnerships with your care team. Prior to COVID, we were really focused on the use of telehealth, and now obviously we have re-upped that focus, despite some delays that have happened due to COVID. One of the really exciting projects that we're working on right now, and that Dr. Zorowski and Daniel are taking the lead on, is working with the APDA. We're working to develop a kit of activities that we can send to individuals with PD and their caregivers that you can use in your home. And part of that kit could, if you decide to opt into a research study, involve some research that will be paired with it. But we're really working with the APDA to help develop some longer term solutions around things that individuals with PD can do in their home safely. So I would love to come back and talk specifically about some of the research endeavors that we have going on. We're very focused both on individuals with PD and healthy practices that you can do at home, as well as caregivers who are often not the focus of research, but really should be, because they're a very important part of that care team. So I would love to come back and talk about research, but today, and to keep us on topic, I will hand the baton back to Dr. Zorowski and Daniel to wrap things up. There's a link to my lab and our contact information down there, should you be interested in any of the endeavors that we have going on. And at our lab link, we do have, anytime we are approved to recruit for research, you can always check in and fill out an informational survey on there if you're interested.
Thank you. So it's really been a pleasure speaking with all of you today. Wish we could be in person, but this is the next best thing here. And we'd really appreciate any feedback you might have. Your opinions matter to us, and we'd love to always improve our presentations and want them to be as helpful as possible. So there's two ways, and I know we're going to get to questions next, but I just want to highlight this here. There'll be two ways to access the survey. Daniel will go ahead and put a link to the chat for you, but you also can scan this QR code if you open up a mobile device and open up the camera and just sort of hover over the link. You'll also be able to access the link there. So at this time, we'll open it up for questions.
Great, thank you so much. That was such a helpful presentation, and we have had some questions come through.
Okay.
I want to encourage everyone, if you have a question, please type it in our Q&A box and we'd be happy to address it. So the first question I want to share says, does one need to have home care ordered in order to get an in-home evaluation from OT? And she said, if so, does an RN or PT also need to come and evaluate and treat? If a patient can get out and about, but wants a home evaluation, how can that be done?
Yeah, that's a very good question. And it's going to depend on your insurance, of course. And so, yeah, that's a very good question. And it can be a little bit tricky because the rules around home health, you're right in that whoever asked the question, and that there are rules from insurances about like who can receive home health and who cannot. And so, but there are OTs that do go into the home. And I think what my suggestion would be, if that is something that you feel would be really beneficial, go through your neurologist and ask for a referral, and the folks in their clinic can help sort of navigate the insurance challenges and get you to the people that you need to get to.
Sorry, I was on mute, but thank you. Someone else has asked, what are some pieces of adaptive equipment that you recommend that people with Parkinson's have in their house?
Yeah, that's a really great question. I think sort of generally speaking, reachers are fantastic just because they're accessible, not very expensive, and can definitely help prevent some falls and those sorts of things. But that becomes really person specific. Which is why we would, I would love if every person that had a diagnosis of PD would see an OT regularly, even yearly, to really evaluate what would the best piece of equipment be for you. Kind of general things that OTs recommend sort of to all people sort of aging in place in their home would be like shower benches if you're having a difficult time standing, for long periods of time to take your showers, and grab bars, so that you're safely able to get in and out of those things. I will tell you that there are, hundreds of different types of shower chairs, and it really, we wouldn't want to recommend one and then it not fit for the space that you have. And so it really would be a great opportunity to have somebody come out to your home and recommend specifically for your house. But those are kind of general ones. Sock aids again, adapted shoes, kind of the ones that shoelaces like we put on the screen. Some of those common ones are the ones we included in our talk. And so those will also be outlined in our handout so that you're not having to remember all of those. You can definitely refer to our handout.
And great. And I just wanted to let everyone know that I will be sending the handout
Good.
along after the presentation today. So you'll have all that information for your reference in the future. And someone has said, you mentioned depression and anxiety earlier in the presentation, and I struggle with apathy with my Parkinson's. Do you have any tips for our recommendations for people who struggle with apathy and how they can get back to their old routine?
Yeah, no, that's a great question. And one that actually in my doctoral work, I just graduated this past year, that was really something that kind of bubbled up as an unmet need for folks living with PD, is sort of this mental health kind of area. And fortunately, we have a pretty strong background in mental health, and the idea of staying sort of connected to the things that matter really do. And I think we all can relate to that right now, right? Like we're not all able to do the things that we need and want to do the same way that we've done them before, and have had to kind of modify and pivot. And so I do think meeting with an occupational therapist would be helpful to sort of talk through what are those, most meaningful things, and what kind of tips and tricks could we help implement so that you're able to continue participating in the things that you want and love to do. So that's sort of my general answer from an OT's perspective. But I also think it is really important to meet with your neurologist and to discuss those challenges as well, because there are, high rates of depression as well for folks with PD. And so it's really, really important to kind of piece out what could be apathy, what could be depression, because you may need to be followed by a doctor for the depression part of it as well. But it's a great question, and it's one of those things that we are actively sort of looking at and doing some research around, because it's such an important piece of a person's overall health and well-being. So thank you for the question.
That's great. I'm glad to hear that there's research being conducted about it.
Yep, absolutely.
Yeah, I was going to say there are some really great research studies going on around those different components. And I know I saw a poster now, I guess, a million years ago, but pre-COVID, where they were really looking at, is there a way to essentially diagram out, or, as much as it makes it sound like it's not natural, can you diagram something like apathy into your day, where now it is a time to sit and think about what the other person is thinking? And so I think there are some approaches that are out there that people are working on. Unfortunately, there's not a lot of evidence necessarily for those practices yet, but there are active things going on to try to help with those issues.
Great, thank you. And someone has asked, people with Parkinson's can have issues with sexual health and functioning. Is that something OTs can help with, or is there another separate therapist or doctor that they should see for those issues?
Another fantastic question. We actually had two case studies to do for today, and for the time constraints, we actually had to take out one of the case studies. But the second case study we were going to talk about was upon evaluation. We had a client who, when we kind of go on top priorities, sexual health was at the top of her kind of priority list to talk about. And it absolutely is something that you can talk to your OT about. Similar kind of recommendations in terms of sort of, having to be mindful about kind of the on phase of your medication and when you're scheduling, meaningful activities like sexual activity as well. But there are specific sexual health professionals as well. And so, yes, OTs can help to a certain point in talking about things like, scheduling, again, kind of matching on phase with the things of your medication with the things that you want to do. Also just sort of the physical aspect of, positioning and all of those sorts of things. There's definitely aids for that, as well as really encouraging people to stay physically active in other ways, just because we know sort of, and I'm sure Jamie's going to chat about, staying physically active can have a variety of health benefits. But yes, it's absolutely something you can talk to your OT about. I'm very happy somebody asked the question about it. And then also there are sexual health people that are more experts in that area that you could also be referred to as well. So thank you for the question. It's an important one.
Absolutely. And I do want to say that someone else actually shared a question too. They said, can fatigue and depression and apathy, can they be mistaken for one another?
Oh my gosh, absolutely. Which is why I suggested, following up with your neurologist to talk about that, because as OTs, we cannot diagnose that, right? And the difference of those things. But yes, very important. And yes, they can all sort of play on each other and look and intermix basically.
Mm-hmm.
Yep, that's a really great point.
And someone has asked, you mentioned meditation and mindfulness.
Mm-hmm.
Do you have any online resources that you can share for people that might want to learn more about that?
Yeah, absolutely. I'm not going to think right off the top of my head, but that's definitely something I'll write down and add so that when you email everybody out, Anushka, I'll put it on there for that.
Great.
I think also just to follow up with that, the APDA sponsored a yoga program for individuals with PD this past summer, I believe, which is fully online. So I don't have the link for that handy. I'm sure Anushka or somebody with APDA can put that out there, but I know that there is an online program through APDA, and part of that is a it's not meditation specifically, but there is a meditation component to the yoga program that was done.
Absolutely, and I'll share that information in our post-event email, because it's really kind of two birds with one stone. You're getting that physical benefit as well as some mental and emotional benefits too. Someone has asked, can OT professionals give me advice or recommendations on driving?
Yes, so there are, yes, another fantastic question. There are actual OTs that work at kind of independent clinics that do driving evaluations. And so that is absolutely something that you can look up in your area. And yep, there are OTs that are trained to do specific driving evals. So they're going to look at things like, physically, are you able to get in and out of your car? Are you physically able to, manage all of the shifting that you need to do, or, pushing the gas pedal and the brake pedals and all of those things? But they're also going to do a driver simulation where they're going to test your reaction time and your ability to focus on multiple stimuli at the same time. And so it really is a comprehensive eval that looks at the whole gamut of skills that are needed to be able to drive safely. But yes, there are OTs that work specifically in driver evaluations, and not just for people with PD. It can be anybody that's having challenges. So great question.
And I do want to add that a lot of our attendees will be familiar with the APDA Minnesota Patient Aid Scholarship Program. And one of the covered costs for our Patient Aid Scholarship is that you can put that funding towards your driver's evaluation. So if cost is ever an issue, please reach out to us and we'd be happy to send you an application for the Patient Aid Scholarship Program.
That's fantastic.
And someone else has added, I have a lot of fatigue during the day because of my Parkinson's. Do you have tips for fatigue management?
Yeah, that's a great question. And Kristen, definitely you can hop into if you have specifics. I think to me, my answer would be sort of living and trying to accommodate, right, the fatigue, and being sort of more mindful about what you schedule when, and scheduling times for naps and all of those sorts of things so that you can continue to do the things that you want, or making that priority list so that that maybe, again, yoga is something that's really important, that sort of bubbles up to the top of the list. But I do think sort of being mindful of kind of having to adapt and adjust to it while also making, kind of a priority list. But Kristen, you can definitely jump in.
Yeah, I was just gonna, this is another one of those great places to engage your care team. Sometimes that tiredness and fatigue can be due to other things, such as disruption in your medication, and especially issues with sleeping at night. And so if you're actually having issues with nighttime sleeping, that can go beyond, yes, you feel sleepy during the day, or yes, you feel fatigued when you try to do activities, but it may be because you're not getting a good night's sleep. And so your care team, your neurologist, your OT, your PT can really focus on maybe something like a sleep study or even a CPAP can actually help you feel better during the day, as well as getting a good night's sleep. Issues with incontinence during the night and things like that. So sometimes it's a two-edged sword of treating what's happening right now so that you can get through the day as best you can and schedule those activities when you are feeling as best as possible, while also proactively looking at the things that are causing, or that are at the root of that fatigue. So I would definitely highly encourage you to engage your care team around that question. Again, this is another one of those very valid, we hear this a lot, that fatigue is something that helps to really shape how your day unfolds. So.
Great, thank you for addressing both of the prongs of that question, both with the fatigue and then the underlying possible sleep issues, because sleep problems can be so common with Parkinson's. And then for our last question, just someone has said, how do I get an OT to come to my house and address it for safety and make recommendations on any changes I should make?
Yeah, it's a great question. It's going to vary kind of insurance to insurance. And so I think that always a good first step is to make that appointment with your doctor so that your neurologist can and their staff can help you get the services that you need and be able to kind of navigate some of the insurance challenges because that can be a challenge, unfortunately. But yeah, I would just, again, engage your care team about that question and bring that up and say that you would like an OT eval to, an OT to come to your home to do a home safety evaluation.
And if I can just add on to that as well, I think this is one of those things, sometimes that goes really, really well. And sometimes your first answer isn't what you were looking for. This is definitely one of those places where advocating for yourself and what you know you need is really important. So don't feel that you can't ask those questions or advocate for your own health. I think OTs and PTs can do a great job of in-home health and safety, and that's where a lot of those catastrophic falls and other issues happen. And there are programs out there. There are OTs that spend their entire day in cars traveling from house to house and never are in a hospital. So those people are out there, and looking for them sometimes is the hard part of the work.
Great, and I do want to chime in on that. So as you all know, a key function of the APDA Information and Referral Center is to help you find resources just like that. So if you're looking for an OT to come into your home, please reach out to your local APDA Information and Referral Center, and they would be happy to help you do some research in finding someone, who is compatible with your insurance, who can help provide that service. We're always happy to help you find those resources in your community. So with that, I think it looks like we've hit time. So thank you everyone for asking your questions. Thank you especially to our speakers, Sarah, Dr. Pickett, and Daniel, for sharing with us and taking the time to be here today. We really appreciate it. And I just wanted to say, if we didn't get to your question today, please consult with your occupational therapist or physician, and we'll also be in touch with the handout that Sarah, Daniel, and Dr. Pickett put together. So we'll be emailing that handout in case you want to refer to that in the future. So thank you to all three of you. We really appreciate it, and have a great rest of your day.
Thanks, you too.
So we will now take a 5-minute break, and we'll be back at 10:50 for our next presentation about current physical therapy techniques for Parkinson's management. Welcome back, everyone. And our third speaker today is Jamie Engebretson from mHealth Fairview. Jamie graduated from the University of Minnesota Duluth in 2006 with bachelor degrees in biology and exercise science, and she earned her Doctor of Physical Therapy from St. Catherine University in 2009. She is a board-certified neurological clinical specialist and has obtained additional training in various Parkinson's disease treatment techniques, including Lsvt BIG and Parkinson's Wellness Recovery. She has been associated with the Capistrant Center for Parkinson's Disease and Movement Disorders for over 10 years. And in addition to Parkinson's disease, she treats other neurologic conditions such as vestibular disorders, concussion, stroke, and brain injury. And since 2016, she has served on the board of directors for the APDA Minnesota chapter, and she is currently the president. So Jamie, feel free to share with us your presentation, and thank you so much for being here today.
Thank you for having me. And everyone, you can see my screen and the presentation? All
Yes.
right. Want to make sure. So thanks for having me today. I'm glad I'm able to join. So my name is Jamie Engebretson. I'm a physical therapist at mHealth Fairview. I've been practicing physical therapy for 10 years, over 10 years, and specifically with Parkinson's for about 10 years. And the one thing I really love about working with people with Parkinson's is that it's just really rewarding to work with an individual and help them regain that function and improve their quality of life. So today I'm going to share current physical therapy interventions for Parkinson's disease management. And I kind of chose this topic mainly because people kind of will come in and say, what's new? What's the research say? I heard about this in the newspaper or on the news, and I want to know more about it. So I figured I'd kind of give an overview of some of the physical therapy interventions or exercise that's out there. So first, I kind of want to go over what we're going to cover today. And so we're going to talk about the basal ganglia function, motor learning, the role of physical therapy, the benefits of exercise, various modes of exercise, and then exercise adherence. So we're talking about the basal ganglia first is because that's the area of the brain that's affected with Parkinson's, because that's where a lot of dopamine is produced. And so this is a structure. It's in the very center of the brain. There is a couple different components to it. One area in specific for Parkinson's and dopamine is a substantia nigra. So what does the basal ganglia do? It controls multiple pathways, including motor pathways for movement, cognitive pathways, memory, motivation, the limbic system, and so emotion and that connection with memory and movement, and it helps with long-term memory of that area. And then the basal ganglia is also kind of the gatekeeper for automatic motor activities. Those would include initiation of walking, walking mechanics, so like arm swing, step length, postural responses and balance, functional movements, so getting in and out of bed, sit to stands are all functional things. It also helps with facial expressions and then swallowing as well, which I'm sure you heard about that earlier this morning. So these are all automatic things. These are things that you don't think about. You learned them so many years ago as you were a baby growing up and everything. And they all come just natural now. So unfortunately, the basal ganglia, the function kind of changes with Parkinson's. There's a dopamine depletion that occurs and it impairs the automatic control of well-practiced daily activities. And that ends up resulting in movements that are smaller and slower. And so a lot of times people see it gets shuffled steps. They can have reduced swallowing. They have a decrease in blinking and eye movement. And you don't really end up seeing a lot of these motor symptoms until the dopamine has been depleted about 50%. And so since that, the physical symptoms don't come on until that time, a lot of times those changes are slow. And so someone with Parkinson's may have a lack of awareness of those motor changes. And so a lot of times it's family members that end up kind of noticing these changes, like, oh, you're kind of walking a little bit slower. You're not swinging that arm as much. And they're the ones that kind of notice those initial symptoms or those even changes as the disease progresses, because the individual with Parkinson's might not know that or recognize it as much. So we kind of need to talk about motor learning in order to talk about the benefits of exercise. And so what is motor learning? It's a set of processes associated with practice and experience, leading to relatively permanent changes in the capacity of movement. It involves multiple areas of the brain, including the basal ganglia. And so you're stimulating the cortex, the cerebellum, everything's going through the basal ganglia as you learn that new task. And motor learning involves 3 phases. So the first phase is learning the new task. The second phase is kind of fine-tuning it and perfecting it, building that confidence in yourself with that. And then the third phase of motor learning is when you learn the task and you can perform it automatically. And you can perform it at any time. You can perform it that same day, you can perform it a month later. It becomes automatic. And then when we're looking at the recovery of function, that ends up being more as like relearning a task or a movement that has been lost due to sensory, motor, and cognitive impairments and pathologies such as Parkinson's. So how has motor learning changed in Parkinson's? So as I mentioned before, it has those 3 phases of motor learning. And that last phase is kind of that automatic process of it. And I had mentioned before that motor learning includes areas of the basal ganglia, which are unfortunately affected with Parkinson's disease because dopamine has been depleted. But the one thing you do need to remember is that motor learning still occurs. However, we just have to kind of adjust our level of expectation for motor learning in Parkinson's. And so, so it might take more practice, external cues and whatnot. And the one thing that they've shown with motor learning in Parkinson's is that people with Parkinson's have a difficulty generalizing a task to another related movement or task. So if you learn how to get out of a chair, a very specific height, sometimes people with Parkinson's have a difficulty transferring that same technique and movement from getting out of like a low soft chair, the couch, or even the toilet. And so that transition can be challenging for someone that has Parkinson's. And then a lot of times with Parkinson's, there's an increased dependence on external cues or input. And so that might be cues that a caregiver or family member needs to learn, or also just kind of using different cues within the environment to help with a skill that's newer, needs to be relearned. And then the retention of that task is affected with Parkinson's. As I mentioned before, that phase 3 of motor learning is to be able to bring that task up, even a month or 2 later. And that can be challenging with people that have Parkinson's. So let's talk about the role of physical therapy. And that's where kind of physical therapy comes in to help with that motor learning. So physical therapy is defined as the assessment and treatment that helps people improve their function and movement, manage pain and chronic conditions, and recover from and prevent injuries or chronic disease. So your physical therapists are your movement experts. And when you're looking for a physical therapist to help you with your Parkinson's, you should be looking for a physical therapist and therapists in general that specialize in Parkinson's. And these individuals should be experienced with a variety of treatment techniques, because one treatment technique doesn't apply to every single person, because no two people are the same. So there's been a lot of research on Parkinson's over the last over 100 years. And the last about 30 years or so, there's been a ton of research on exercise. And so we've really been able to benefit from that right now. And so a lot of the research has shown that exercise is a key non-medical intervention for the management of Parkinson's disease. And so you can kind of think of exercise as medicine. And you need exercise and your Parkinson's medications to work together. So you need to be optimizing your Parkinson's medications in order to be able to fully move and exercise appropriately. And you also need to be able to, in order to move effectively, you need your Parkinson's medications as well. So they kind of work hand in hand. And then exercise has been shown to improve the ease of movement, the reduction of falls, and improve the quality of life. And the one thing that they have found with exercise is that if you stop exercise, you don't experience the benefits. And the same thing is true, like if you stop taking medication, you're going to have a change in your management of your symptoms from Parkinson's. So exercise is definitely really beneficial for the management of Parkinson's disease. So I talked about this research that is going on right now and has been going on for the last like 30 years or so. But what does the research say on different techniques? So aerobic exercise is doing the cardiovascular fitness. Research has shown that treadmill training results in improvements in gait mechanics of step length, gait speed, as well as postural control. And the benefits of this is really intensity dependent. And so high intensity gait training enhances the dopamine circuits, so they are more effective. Now, gait training and treadmill is not for everyone. And so they've actually done research on cycling. And cycling has been shown to improve cardiovascular function as well as inner limb coordination and strength. However, with cycling, intensity matters too. And you must cycle at a moderate to high speed. Now, all this research has been shown, intensity matter to high. When they were doing this research, they did have people that were non-exercisers, and people had they needed about 8 weeks of training before they could actually reach those higher levels of intensity. And so you can't just, a lot of people can't just jump into that high level of intensity right away. So can the benefits of aerobic exercise carry over to other areas? In 2008, a study by Stubb et al. Entitled "A Single Bout of Aerobic Exercise Improves Motor Skill, Consolidation, and Parkinson's Disease." So this study looked at the retention of balance training with and without aerobic exercise. So they had 2 groups, and one group did about 30 minutes of aerobic exercise. In this case, it was cycling. And then both groups then did balance training. And then they looked at how well these people that had Parkinson's were able to maintain the training of balance a day or 2 later. And so they looked at that retention of that balance training. And it showed that the individuals that did the 30 minutes of aerobic exercise prior to balance training had improved retention of that task. So they performed better when they did the follow-up. And so strengthening, there's been research on strengthening as well. And the research has shown that you have long-term improvements in strength when you have a progressive resistive exercise program versus a standard strengthening program. So your standard strengthening program is not maybe as individualized, it's kind of a generic program. And your progressive resistive exercise program keeps evolving and changing as you meet, and the task gets easier. And so the research has shown that this progressive resistance programs generate larger force capacity of the muscle, which can affect motor symptoms as well. And that they kind of showed that the progressive program should be guided by a professional. So aerobic exercise and strength have been around for a long time. There's been a lot of new techniques and things that have been coming out in the more recent years, and I wanted to touch on those and show the research behind them. And so dance and Parkinson's is one of them. And so a study of tango and Parkinson's disease by Duncan and Earhart in 2012, and then a follow-up done a year later by Foster, looked at doing an hour of tango 2 times per week for a full year. And they looked at that group versus people that didn't do exercise. And at 1 year, they found that there was a 28% improvement in motor symptoms. And then at 2 years, the tango group reported an increased participation in complex daily activities, recovery of activities that were lost, and engagement of new activities. So that's pretty neat that, after 2 years, they're able to start doing those new things. So that motor learning that we talked about in the very beginning. And then a systematic review of the literature in 2020 showed that evidence that dance can improve motor impairments of balance and motor symptoms of Parkinson's disease in mild to moderate disease level. Now, when they were looking at all these studies, what they found was that when the exercise groups focused on one type of exercise or dance, it resulted in better outcomes. So let's say they focused on tango the entire time versus doing tango and the waltz and the foxtrot. That almost like was too much to show a significant improvement. And so they've done a lot of research on the motor improvements with dance, and they're starting to look at the non-motor improvements and other benefits of social benefits and cognition. And so there's a lot more research that is being done, and that's needed to continue to see the full benefits of dance with Parkinson's. So I want to talk about boxing, because boxing has really taken the nation by storm. It's a very popular activity in the more recent years. You can find clubs all over the country and actually all over the world. And so when you actually look at the research, there's minimal research on the benefits and effects of boxing. And in 2019, there was a literature review, and the research showed that boxing has a small effect on balance, functional mobility, and gait speed. And it has a moderate effect on endurance and balance confidence. Now, when they did this literature review, they looked at a vast majority of studies, and a lot of stuff had to be excluded because the studies weren't strong. And so they ended up it boiled down to just a couple studies that were actually strong and showed strong studies that were randomized control and whatnot. And so what they concluded when they did this literature review is that there's more research that is needed to really show those benefits. Now, I have people that come and see me, and they do boxing classes, and they will tell me how beneficial it is. And so, maybe the research hasn't quite caught up with what it's doing, but overall, there needs to be more research on boxing. Now, looking at Tai Chi and Parkinson's. So Tai Chi incorporates the mind and body with controlled movements and breathing. Typically, these movements are slow and controlled, and a lot of weight shifting is focused with this activity. So in 2014, a systematic review showed beneficial effects on balance and functional mobility in people with Parkinson's disease. Did not show any evidence in improvement in gait mechanics or endurance, which kind of makes sense. Tai Chi, like I said, is a lot about weight shifting and slow and controlled movements. And so It does make sense that, endurance might not improve and gait mechanics might not improve, but you would see maybe an improvement in strength and balance. And then the research also kind of said that safety of Tai Chi improves when you use your Parkinson's medications. So they kind of looked at people that were doing Tai Chi without doing Parkinson's medication versus with, and they just got improved benefits, decreased falls when you're doing your Tai Chi and you're taking your medication at the same time. So Tai Chi has been shown to be an effective activity for individuals with mild to moderate Parkinson's disease. And another area that there's been a lot of research is on amplitude training in Parkinson's. These programs are based on the principles of neuroplasticity. So the neuroplasticity principles are, some include if you don't use it, you'll lose it. If you use it, you improve it. Intensity matters, the activity matters, and that carry over to function as well. And so these amplitude training programs typically focus on large amplitude movements and intensity. And overall, they focus on a transition to function and that carry over to functional activities. Examples of these programs are Lsvt Big and then Parkinson's Wellness Recovery. Now, research shows that amplitude training can transfer to improved speed and amplitude of activities such as reaching and writing skills, as well as decreased motor symptoms and improves function. So the last couple of things I've been talking about, dance and boxing and Tai Chi and amplitude training, why are these newer techniques working? And so the thought is also that, so tasks that are difficult require you to learn a new skill acquisition, or tasks that are complex require that more areas of the brain to be involved. And so that then changes the brain and you're able to use your dopamine more. And these newer techniques include high effort, intensity, complexity, and they're challenging. And then repetition is necessary to induce that sustained changes that transfer and carry over. And so if you're thinking of dance, you're learning a combination of steps. You're going to do that over and over. And so that's that repetition. And then you build on that. Boxing, you might do a specific combination as well. And you do the repetition and you keep building on that. And then even with like amplitude training, it's the same sort of concept. So we talked all about exercise and the research behind it and how great it is for you, but then you have to actually do it. So exercise adherence is a huge thing that's going to help you with managing your Parkinson's symptoms. And I will say exercise adherence is challenging for anyone. So you think about New Year's, you make your New Year's resolution, and a lot of people say, I'm going to exercise. I'm going to join that gym. And so they buy the membership, maybe they get a treadmill or something, and they are really good for a month, maybe 2 months. And then all of a sudden it kind of fizzles out. And so that ability to create exercise and an exercise program as a habit is challenging, I feel like, for everyone. It also can be challenging staying accountable to your exercise program after you complete like a bout of therapy too, because you have that one-on-one training, you have that motivation that, oh, they're going to ask me if I did my exercises yesterday, and I need to make sure I tell them yes. And so that can be a motivating factor. And when you look at people that have Parkinson's, being able to adhere to an exercise program and do it regularly, that can be affected because of the lack of dopamine in that basal ganglia. Because I had mentioned before the function of the basal ganglia, also there's a component of motivation within that area of the brain. And so if that dopamine level is down, motivation can be affected. And so then trying to get someone to do sometimes just daily things, but then also adhering to an exercise program that's supposed to be challenging and high intensity can overall be a challenge. And so ways to help carry over that accountability of doing exercise once therapy kind of gets you started and everything. One thing that can help kind of transfer off of after you do therapy is the participation in a community exercise group. And one that specifically focuses on people with Parkinson's can really help. Now, unfortunately, we're in the middle of a COVID pandemic, and some of those classes aren't occurring in person, or you might want to be staying at home because of various social gathering restrictions in your area. And so even finding someone, maybe it's a family member that you are exercising with every day so that you're held accountable, you can hold each other accountable, can help. And one thing that's really beneficial right now, I think also with technology, is that there are so many virtual exercise classes that are out there right now. And so you can still get that connection with someone else. I know it's not the same, but it can help kind of hold you accountable. You can get a little bit of that social interaction too. And then I know the APDA has a whole list of exercise groups across the whole country. And then there are a lot of exercise groups that are doing virtual, kind of probably in your own community as well. But there's resources out there. So things you should be considering with exercise is before you even start, you do want to consult your medical provider and then get guidance from your rehabilitation team. So PT, OT, and speech. So they can help you build up to an appropriate intensity, kind of the stuff that they're talking about in the research. And it's also important to remember that not all exercises and interventions are suited for everybody. And so that is why it's good to have your rehab team involved with your care so that they can help guide you. And then interventions that you decide to do for exercise should also carry over to functional activities. So if you're doing an exercise class for an hour, maybe it's a community-based one, and you're putting all this energy into it and motivation, you need to take that same energy and carry it over to other things that you're doing throughout your daily life and activity so that you can still carry those benefits into functional things. And then exercise should be enjoyable, but also it should be challenging. So you don't want to, if you're so not interested in doing dance, maybe dance is not your thing. Find an activity that is enjoyable for you. So the take-home message that I want you to get from this presentation is that your therapists on your team should specialize in Parkinson's disease. And PT, OT, and speech should be on your team from the very beginning and an integral part of your team as the disease progresses. Because remember, I said that your motor symptoms don't develop or don't kind of present until that dopamine is depleted by 50%. And then you need dopamine to help kind of with motor learning. It is essential that you do therapy right away so that you can activate those neural pathways. And then you should be consulting and kind of going back to your therapy team with your doctor's guidance as well when you need to kind of change your approach on exercise or when your function has definitely changed, so that they can kind of keep making you so that you can stay independent. So that kind of goes over to like regular assessments and treatments so that you can stay as active and independent as possible. And so your exercise program also should be challenging for you. Intensity matters. Research shows that intensity matters. You need to be doing things, especially exercise, with purpose, not just going through the motions. And then lastly, exercise is important. You should be doing it right there with taking your medication so that you can improve your quality of life and stay as independent as possible. And it's not too late to start exercising. That's one thing that I do want you to make sure that you realize that it's not too late, whether or not you were diagnosed last month or even a few years ago. And it's not too late to start exercising because you can reap the benefits. All right. There are any questions?
Jamie, thank you so much for that great presentation. And we have received some questions, but if anyone is interested in asking more questions, please feel free to drop them into the Q&A and we will address them. So I want to get started by sharing one question that someone asked. They said, we heard on TV that St. Thomas University is developing I think it's SAFV test, like safe V test, like inflatable to help prevent falls. Are you aware of this?
So I actually just looked that up because I had not seen that, but it looks like the news just recently did that. And when I quickly just scanned through it, things, it doesn't look like it's to prevent falls. It looks like it's almost to prevent injuries from falls when I kind of looked at that. But there are things that are being developed quite often, and it is interesting all the different things that are coming out nowadays, especially with research and everything.
Absolutely. So thanks for clarifying that. And someone has asked, is there a difference between indoor and outdoor cycling in terms of benefits for people with Parkinson's? And what is moderate to high speed for seeing benefits with cycling?
So that moderate to high speed level is actually looking at your target heart rate. And so looking at exercising at 60% or more, which is why you should, if you're looking at going into this, maybe even get guidance from your rehab team so that you're aware of what level that is safe for you. Because it also, you have to look at other past medical history and other components that could be playing a role in that. So, but research is kind of showing that it's 60%. And in terms of outdoor cycling versus indoor, a lot of the research shows indoor cycling because you can kind of control that better. But you can easily apply it to being able to do outdoor stuff as long as your balance and safety with cycling is good. And the one thing that you do have to think of is just maintaining that, moderate to high intensity level. And so there are other ways to kind of rate intensity too that correlate with heart rate. So speaking with a physical therapist about knowing how to see that correlation would be beneficial.
Great, thank you. And someone has asked, kind of, relating to the whole theme of cycling, what is your opinion of the TheraCycle?
So that is more of, if I can remember correctly, I think that's more of a recumbent bike. And again, it's going to be all about the that intensity, because that's where, if you sit there and look at just the aerobic exercise benefits, like I said, the treadmill and cycling kind of showed similar results in it because it's all about the intensity that you're doing. So if you're doing a TheraCycle, you still need to do that higher intensity, and it might be safer for you to do that in terms of your balance than on a road bike or a different type of cycle.
Great, thank you. And someone else has asked, how much exercise should I be doing to see benefits in terms of minutes per day, and how many times per week?
That's a great question. So, every day would be great. And research has kind of shown like up to an hour, 30 minutes to an hour. And it all depends on, what activity you decide to choose. But I would, a lot of times the American Heart Association, says that doing exercise most days of the week for at least 30 minutes is beneficial from a cardiovascular standpoint. And so when you're stimulating at that level of that moderate to high level, you're going to get that response to dopamine too.
Great. I think that's really valuable guidance. And someone else has asked, what are the differences between LSVT big and Parkinson's wellness recovery?
So they're actually developed by the same person. And there's just, the concepts are, when you look at the development of it, they're very similar. So they're, like I said, based on the principles of neuroplasticity and large amplitude movements. The difference is just ends up being the movements that you end up doing. And you can technically adapt both techniques to various levels. So if someone maybe can't stand, you can technically do both techniques to modify for an individual's various functional levels. The one probably difference is LSVT is a little bit more of a program in terms of they have like a hierarchy skills that they kind of follow and stuff. And then power can be a little bit more individualized, or the therapist can kind of change things, and it really evolves as you're kind of doing it. So I say they're very similar, but it all depends on how the therapist kind of approaches the technique. If that somewhat answers the question.
Yeah, it does, definitely. And someone has asked, they said, I struggle with stiffness that makes exercise difficult. What do you recommend for that?
Can you repeat that question one more time?
She said, I struggle with stiffness that makes exercise difficult. What do you recommend for that?
So, consulting with your medical team, because, are you optimizing your medications? That can always, carry over to rigidity and stiffness. Different types of exercise can help address rigidity and stiffness too. And so it ends up being individualized. They have shown that strengthening specifically can help with rigidity. And then the large amplitude movements can also address that too. And so you end up kind of combining a lot of techniques. And so seeing a therapist that specializes in Parkinson's should help with figuring out what exactly is best for you as an individual.
Yeah, that's super helpful to know. And someone has said, I think it's a little similar. They said, I use a wheelchair. What exercises can I engage in?
Yeah, there are some great exercises that you can do sitting. Like I said, all the aerobic stuff, you can modify that to sitting with cycles. A lot of the large amplitude movements you can do sitting, even laying down. If you go see a Parkinson's specialist, they can adapt a lot of the research and the techniques to where your level is, whether it's wheelchair bound or sitting or laying and standing. So to keep you safe, like moving.
Yeah, that's super helpful, and especially to know about the different types of, like chair yoga. I think that's offered, and like chair resistance exercises and stuff. So that's really good to know that there's still a lot of things you can engage in.
Yeah, a lot of the stuff can be adapted.
Mm-hmm. And someone has asked, what is considered regular assessment for PT? Should I be going in every year or every 2 years? What should I do?
Yeah, that's a great question. So I am a pro in, a very big advocate. And as soon as you get diagnosed, you should be seeing your rehab team. So they can kind of get you started in the right track. And the frequency on how often you do get reassessed by therapies is really going to depend on how your disease is progressing. There are some people that I'll say, I want to see you next, in a year. Some people that are really great at adhering to the exercise programs, I'll say, you know what, I'll see you in 2 years, or when you notice this is getting challenging, or something that some daily activity that you're noticing has changed, come see me for that. And so, I mean, you do have to, insurance does kind of dictate a little bit of how often you can get seen, mainly because a lot of your insurance wants to see a change in function, and they want to see improvement. And so that does play a role in how often you end up seeing a provider.
Great, that was really helpful. And someone has asked, they've said my heart medication limits my heart rate. Can I still get to high intensity, or how do I get to high intensity?
Yeah, so there are other like subjective scales to use to determine how hard you feel like you're working. Because yeah, certain medications can blunt your heart rate response. With different movements with Parkinson's, going from like laying down to sitting, your heart rate has a blunted heart rate response too. So that can be not only from your medication, but sometimes from Parkinson's as well. So there are subjective questionnaires or scales that you can use to help guide how intense an activity is for you.
All right, that's really good to know. And someone has said, what kind of exercises do you recommend for people with more advanced Parkinson's who still want to be active?
Yeah, and like I said, exercise is never too late. So that's a great question, because you really want to maintain that function and ease of movement. I know I have seen an individual that came in that was barely walking, and we started doing exercise and activity, and it was all seated, or we even did stuff in bed too, and working on more functional movements. And you could just see the improvement that they had. So like chair yoga is great. There are community exercise groups that in the Twin Cities here that will actually kind of modify depending on where you are in your functional mobility and ease of movement, and the disease process to do appropriate levels for you. So there are groups in the Twin Cities here that will do specifically chair activities, and they might use aerobic equipment that you're sitting so that you can still get that aerobic benefits too. So, but I would encourage you to see your physical therapist and your rehab team so that they can give you the guidance for you as an individual.
Good to know. And someone has just asked, I think, a point to clarify. He asked, what is the relationship between big and loud and LSVT?
So big and loud and LSVT is actually like the same thing. So LSVT is just it's an acronym for the person when they originally started this program. So it originally started as LSVT loud based on the treatment protocol that they gave a very specific individual. And her name is blanking, but part of her name is actually in the LSVT abbreviation. And then they developed the big component based on those principles that they gained and showed that improved with speech or loud portion. So LSVT big and LSVT loud, that's the entire compass of the program. Sometimes people will say LSVT big and loud, or they'll drop off the LSVT piece to it when they're just talking about it. So it's really the same thing, but that's a great question.
Yeah, absolutely, because I know everyone refers to it in a slightly different way. So, And you know, our last question isn't really a question, but we had a message come through for you. Someone said, "We love seeing you, Jamie. Great job, and we miss you." So thank you for being here and connecting with our community today.
Thank you.
And so I think that brings us to the end of our time. So thank you, Jamie. And we are now going to take a 5-minute break, and we'll be back at 11:40 for our final presentation, where a community member with Parkinson's disease will share the personal impact that rehabilitation therapies have had on his life. So we'll be back at 11:40. Thank you. Welcome back, everyone. Our final speaker today is Stu Bauman, a Minnesota Parkinson's advocate. Stu lost his sense of smell in 1999, and 13 years later, he was diagnosed with Parkinson's disease. At that time, in 2012, his employer, Delta Airlines, was offering an incentive for pilots to retire early. And Stu took the early retirement, which gave him time to learn about Parkinson's. After many months of self-education, he was ready to become a voice and advocate in the community. As a volunteer, Stu served for 4 years on the board of the APDA Minnesota chapter. And his belief in exercise as medicine kept him busy at the YMCA, which sparked his effort to bring the two nonprofits together to bring pedaling for Parkinson's to the YMCA at several branches across the Twin Cities and beyond, free of charge to people with Parkinson's disease. So Stu, welcome, and thank you for being here today.
There I am. Do you want video? Because if you do, I'll take it.
I've just sent you an invitation to start your video. And we can see you. Thank you.
Oh, I can't see myself. That's okay. Well, good. Thank you very much, Anushka. I would also like to thank the APDA in Minnesota and all our sponsors today for providing us with this symposium. Before I begin, I want to touch just a little bit on something that Jamie said in the last session. And that's the question was about biking outdoors versus indoors. For me, definitely biking indoors, I work harder. And I think that will be true for just about anybody. It's much easier to push yourself if you're indoors in a class on a spinning cycle. So just to touch on that, that's good. So today I would like to share my personal experience navigating life with Parkinson's disease. And the thing that, I want to emphasize the importance of a healthy mind and body, physical and mental well-being, as well as emotional and social well-being. And I'll also talk about some of my ideas on exercise, which we've heard a lot about, other therapies, and support systems that we have with Parkinson's disease. So as Anushka told you, about 10 years ago, something wasn't right and I got diagnosed. But when I was a high school swimmer and a college swimmer. And so when I was swimming at the YMCA, I noticed that my left hand recovery on my stroke wasn't working very well. There seemed to be a glitch or a hiccup in it. And I did not swing my left arm when I walked. And I was losing dexterity in my left hand. So my wife, who used to be an OT, arranged for a visit to the neurologist. What were my symptoms? Well, I just talked about arm swinging and dexterity. I had some muscle tightness and my sleep was being interrupted by muscle cramps. And it wasn't until my wife said, oh, you know, in 1999, this was 12 to 13 years before I was sitting there in that chair, Stu lost his sense of smell. The doctor perked up right away and factored all those things in, and pretty quickly I was diagnosed with Parkinson's disease. So the doctor said exercise is important, and like to say in the community, movement is medicine. And as like Anne said, Anne St. Jacques in her talk about speech is use it or lose it. It's very true for all our muscles. So what else could I do? Well, I learned about LSVT, and I think Jamie did a very good talk on that. So I'm not going to go into that, but I went through the LSVT training, and I try very hard every day to do my exercises, but I don't always get them done. Jamie spoke very eloquently towards the whole situation of trying to get it in every day. But at the YMCA, in addition to swimming, I also found classes on yoga, which is a type of stretching, and it's very good for flexibility and for range of motion and for balance. And Tai Chi, which is a type of martial arts that was mentioned, I find it very good for inner calming and getting a good mind to body connection. And then Silver Sneakers, which is one of my favorites at the Y. It's now called Forever Well, but it's a program. It's similar to LSVT in that it has big movements. And if you know LSVT, you can incorporate all that into Silver Sneakers, being good for mobility, range of motion, flexibility, and balance again. But I found there were things I could do on my own. One of those is Nordic walking. I got some sticks and started Nordic walking using arm and leg motions. It's the bilateral use of arms and legs is good for cross brain training. And then biking, which we talked about, is good for balance. Then there were a couple of PD specific programs. Pedaling for Parkinson's is the one that I really like. It's a spinning class on the bicycle, like we talked about. The second one is rock steady boxing, which was also mentioned, which is not man-to-man, but it is against bags and using instructors with soft pad targets. It includes things like jump rope and footwork, and it's very, very good for balance and coordination. And it's probably more aerobic than any of the other classes. In a few minutes, I'm going to come back and talk about these two programs because they're very special to me. So in addition to my exercise regime, my new job in retirement included learning about PD. How do you learn about PD? Well, I read a lot, and I tried to listen to my neurologist and the other professionals, such as the PTs, the OTs, and the speech pathologists. And the other one that I really like is support groups. And when I say groups, I mean more than one. I found 3 that I like, and I try to attend them regularly as possible. However, we know that COVID-19 restrictions have limited those. If you've never heard about or gone to or considered a support group, I can tell you that they are not gripe sessions. We don't sit around and complain. What they are is good peer support groups. We have guided discussions, and all of our leaders are trained and qualified to lead discussions. And we get access to resources that way. And it helps with the perspective of the disease because you're with people who understand what you're talking about and going through similar things. So in retirement, I also needed hobbies. One of my hobbies is playing bridge. And although 20 years prior to diagnosis, I played bridge with my wife against her parents, but it wasn't that often, and it was a lot of fun. But when I was diagnosed, then I decided I'd get into bridge more vigorously. Started going to the bridge center and started to sharpen my game. In addition, in college, I had taken a foreign language, and I decided that having not used it for 40 years, that maybe it was time to brush up a little bit. And I found out that, well, what's the language? Norwegian. Well, you can speak Norwegian to several people in Minnesota, that's true, but in the rest of the world, not so much. But I found out that at Myndekirken, which is the Norwegian Lutheran Church in Minneapolis, they have weekly classes available year-round. They run for 10-week sessions, 2 hours a night, once a week. And so I enrolled in class. And initially, it was a lot of grammar review and things like that. But I've moved on now to where we're reading a novel in Norwegian. And it's a crime novel, and it's very interesting. It's difficult, but it's very rewarding also. As far as a sense of self-worth in retirement or in later life or with any disease like Parkinson's, self-worth comes from volunteerism, from a feeling of contributing, giving something back to the community. I volunteered with the APDA, as Anushka told you. I served on the board for 4 years, doing things like this, public speaking and organizing and fundraising. I also volunteered at the Y. Being a swimmer, I decided that I could become a swim official and help officiate the youth swim meets. And my church has an active youth group, and I helped drive bus for that. So I got into some youth ministry at the church. Fast forward to 2018, because of my experiences with the APDA and the YMCA, I am proud to say that I helped bring Pedaling for Parkinson's to the Twin Cities YMCA system. It's provided free of charge to anybody with Parkinson's disease. You do not need to be a member of the Y. APDA and the Y also are bringing rock steady boxing to the Twin Cities. And a year ago, I would have told you it's going to start soon, but COVID-19 restrictions have put it on hold for now. But those are the two things that I'm most proud of in the last 10 years in my volunteer work, is bringing programs to the community. Okay, we'll go back to the 2012 to 2016 time frame. My exercise was part of my routine that I developed to keep my daily schedule going. As Jamie talked about, it needs to be something you try to do every day. So my routine was exercise in the late morning and eat lunch, and then have the afternoon free for appointments and volunteer work. And I got very comfortable with my routine at home. But my wife and I like to travel, and I was a little bit concerned about traveling and how easy it would be for my routine to continue. Well, it was more difficult, and it wasn't perfect, but I was able to do it and make it work. So those first 4 years I call my honeymoon with carbidopa levodopa. Things were really good. The medication helped me keep my body moving and all. But as the disease progressed, so did my symptoms. My abilities decreased, and I had more fatigue, and I was losing stamina. I had more stress in my life. And I was experiencing dyskinesia, which was a side effect of increased doses of the carbidopa levodopa. My body would be twitching and moving full time, 24 hours a day, and it wore me down. So by 2018, I decided to drop all my volunteer duties and the responsibilities. That was the YMCA, the APDA, as well as the youth group, which helped to reduce my stress quite a bit. But the Parkinson's still progresses. Outwardly, my symptoms were not quite so noticeable, but they were becoming more noticeable. Because back in 2015, I had considered getting deep brain stimulation, and I went through all the tests for it. I passed all those, jumped over all the hurdles, and the doctor said, well, you're a candidate for DBS, but it's a little bit early in the progression of your disease for it to be worthwhile. So I put it on the back burner, but I did mentally commit to having DBS at some time. My expectations were I hope to help my tremor, help get rid of the dyskinesia, address my toe curling, and hopefully my sleep interruptions. By late 2019, in November of 2019, I, along with a large group of the team, doctors and professionals, after a meeting with all of them, decided that I would go ahead with DBS. So I scheduled the surgery for March of 2020. And of course, COVID hit about that time, and that got delayed. I was able to reschedule surgery for June last year. And I finished the surgery and started programming in July with Dr. Orehak at Moran Clinic. So the results, well, it's not a miracle. It's not like you wake up and everything's rosy, but it did help with all those symptoms that I talked about. That COVID-19 thing, what it disrupted for me was my daily routine. The YMCA, along with other health clubs, closed. And my self-discipline of doing things on video was not very high, and my distractions were high. I became best friends with YouTube, and I found it easy to procrastinate. My motivation was changing because for the first 4 years, I looked out way far out to the future and kept the exercise program going. Of course, my body and mind were cooperating at the time. So as time goes on, that routine has changed a little bit, and I'm still struggling with it. Jamie explained that very well in her talk. And so my journey continues through twists and turns as I strive to tap all these resources and maintain a steady course. Thank you very much for listening. I will take questions now. Anushka, do you have anything for me?
I just want to thank you so much for sharing your personal experience. I think that the words of experts is so valuable, but it can be just incredibly beneficial to hear firsthand from people who are actually going through the Parkinson's journey. So I want to thank you for taking the time to share with us. We're really grateful to have you here. And if anyone has any questions for Stu, please feel free to share them in the Q&A, or you can reach out to me, the event organizer, and I can get in touch with Stu to share any questions as well. But we do want to thank him especially for his role in bringing pedaling for Parkinson's to the Minnesota Parkinson's community. So with that, I actually think that we are coming up on our final few minutes for today. So again, Stu, thanks so much for taking the time to share your story with us. It really makes a difference to be able to hear from someone with a personal connection. And again, if anyone has any questions, please feel free to reach out. I have received one question. Someone's asking about the pedaling for Parkinson's. So they asked about pedaling for Parkinson's and if there is a leader to help, I think, get people involved in the program. And I do want to say that we were working with Jennifer Menk at the YMCA. Now during COVID, Stu, do you know if pedaling for Parkinson's classes are being offered with masks on? Do you have any information about that?
If my emails and my memory serve me correctly, yes, the Southdale at least has restarted their pedaling for Parkinson's program. It has been on and off and on and off for the last year, but I think they've got that going again. The other branches, I don't know right now. One of the things that happened with COVID was, of course, people got laid off at lots of places. The YMCA lost a lot of their qualified people, which is very unfortunate, but I do think that they have restarted it at least at Southdale.
And just to reiterate to everybody, that is the Pedaling for Parkinson's program at the Southdale YMCA, where people are able to participate while wearing masks and social distancing. And if you live elsewhere in Minnesota or elsewhere in the country and you're interested in learning more about pedaling for Parkinson's, I recommend reaching out to your local INR coordinator to see if pedaling for Parkinson's is available near you. And someone else, Stu, has just said thank you and it was so good to see you. So probably one of the many friends that you've made during your time as a Parkinson's community advocate.
Thank you.
Great, so thanks so much. And with that, I will move on to our closing remarks for today. And I just want to thank everyone involved in making this day such a success. I want to thank you to Anne, Sarah, Daniel, Jamie, Stu, and Dr. Pickett for their wonderful presentations. And for additional information, for answers to your questions, and for resources, please visit our website. And that is available here, apdaparkinson.org/MN for Minnesota. And you can also email or call us via the email and phone number on the screen. We would love to hear from you. And I want to share a little bit of information about some of our upcoming events. The next educational event that we have coming up is the 2021 Spring Parkinson's Symposium. And for your reference, this event will be held virtually on Friday, April 16th. And this event, the Spring Parkinson's Symposium, is the annual collaboration between APDA Minnesota, Parkinson's Foundation Minnesota, and the Udall Center at the University of Minnesota. And we have a great lineup of topics and speakers that are planned for this event. And please visit the website on the screen, tinyurl.com/SSMN2021 for more information. This event is taking place again virtually on Zoom from 9:30 a.m. to 1 p.m. on Friday, April 16th. And I also wanted to share information about our next press session beginning on March 18th. And we are currently taking registrations for this special 8-week virtual program for people who have been living with Parkinson's for the past 1 to 5 years. And this unique program melds education about different aspects of living well with Parkinson's with psychosocial support and sharing. So please email our facilitator, Linda, and her email address is right here on the screen if you're interested in signing up or if you have questions. There is no cost to attend this program, but pre-registration is required, and you can register by emailing Linda. And also care partners and adult family members are encouraged to attend the press sessions as well. So if you enjoyed today's webinar, we hope that you will consider supporting APDA Minnesota with a donation, because with your help, APDA Minnesota chapter can deliver more programs and services just like this one that are needed now more than ever during these challenging times. On behalf of the entire APDA Minnesota chapter, many thanks to our speakers, Anne, Sarah, Jamie, Daniel, Dr. Pickett, and Stu, all of our participants, and our sponsors, Kiowa Karen, Amneal, and Acadia, for supporting our program. If you know someone who missed today's program, if you joined late, or if you would simply like to watch again, you can view a recording on our website at apdaparkinson.org/mn within the next day or two. So thank you everyone again. I hope you have a wonderful afternoon. Take care.